This is a lecture on engagement in rehabilitation. This lecture was originally delivered for the Concentric Rehabilitation group, and I'm re-recording it because we had a few technical problems at the event. I would like to pay my respects to the Indigenous people of Australia and to the elders past, present and future, and acknowledge that the land I'm presented from is land of the Gadigal and Wongal people of the Eora Nation. The learning objectives for this lecture are that you should be able to talk about the features that influence engagement, what kind of strategies that therapists can use to influence those features and increase engagement, and to think very critically about your communication and the way that you set up people's practice and whether you're doing what you can to really optimize people's engagement in their practice. So we're going to have a look at a model of engagement and think about what we can change, and also think about how we maintain engagement. So firstly, to define engagement, I'll let you read through that description there. But essentially, we're looking for it to be obvious that people are actively and effortfully participating in what they are doing. So if we have a look at this model, and then we're going to break it down and look at the smaller features of it, because it's a bit hard to see on the whole model on the screen clearly, but you can see what it's looking for is the features, or what it's outlining really, the features that lead into people's willingness to do treatment and their engagement, then their preparation, their initiation, putting energy into it, being engaged, and then what leads into maintenance. And we'll have a talk towards the end about what leads to disengagement. We're looking at the features that really lead into this willingness and intention to engage with practice. And there's many things there that we can make a big difference to. We can really influence people's practice so that they perceive that they're likely to be able to successfully achieve the things that they're trying to do. We can make sure that people are aware of their capabilities to practice and their capability to change when they do adequate amounts of practice. And we can have very clear discussions with people about the treatment demands. So let's start with outcome expectancies. This talks to somebody's perceived likelihood that they're going to be successful. And what this means is that as therapists, we need to set up practice that people can be successful with. We need to use our skills, and we are very skilled at adapting people's practice, adapting tasks so that people can achieve them. So the practice needs to be achievable, and we can provide evidence to people that they're achieving it and that they're changing, that their performance is changing. And this leads in then to their outcome expectancies, and that feeds into people's engagement with their practice. So if we think about creating practice that is achievable, how do we do that? So if somebody's practicing something that they can't successfully achieve, we need to either change the environment set up for that practice to make it achievable, or we need to modify the task or change the task. So if we have a look at Keith here, and you can see he's got a very marked weakness on his right side. And at the moment he's standing and the therapist is holding him up. So you can see that Keith is not going to perceive that he's having any success with standing at the time. But this has been modified. The environment has been changed, and now Keith is standing with a wall on his intact side. The therapist is there for safety and sort of giving him some cues, but he's now successfully standing up without falling against the therapist, being held up by the therapist. So you can see now he might perceive that he's actually having some success with his standing, and the only thing that has changed is the environment setup of that task. Here we see a man called Eddie, and you see him practicing sit to stand. So in this first video, you can see where the environment has not been set up to maximize his success with this. He doesn't really make it into standing. He has a lot of assistance from the physio. And again, what has been changed here is the environment setup. Again, he's now got a wall on the intact side, a solid height adjustable table in front. He is using his arm a bit, but probably he's not really going to be able to get his weight forward and stand up without doing that. And have a look at the difference here. So now you can see the therapist doesn't really assist him into standing. He basically gets himself up into standing, and then he's able to stand with hardly any assistance at all from the therapist. So you can see his perception now will be very different. So to go from something where he was essentially being assisted into standing and not really making it up into a standing position at all either, to something where he basically gets himself into standing and is able to hold a standing position. And the difference is the environment setup. So we can use an environment setup to create success for people in their practice. Now we see a man trying to grasp a bottle, and you can see with the aperture of his hand, he's not going to be very successful in grasping that bottle. And the modifications that have been done here are to tape his fingers together so that they can work as a sort of a virtual block. It's going to make it easier for him. And to draw his attention to some of the marks on the bottle about where his thumb and where his fingers need to meet the bottle. And you can see the difference in the position of his thumb. He's brought it around into more conjoint rotation. He's brought the ends of his fingers around onto the bottle, so he's going to be much more successful. So again, the change in the environment setup is going to lead to him having a successful outcome as opposed to an unsuccessful outcome. Here we see a stroke survivor called Tony working with Carl Scher. And so Carl first asks Tony to pick up this jar, and you can see that Tony is able to pick it up. He's not really able to adequately release it when he tries to release it. He can't extend at his MCPs adequately to release it. So Carl comes in and sets him up to do some practice of MCP extension. But you can see he does several things in order for Tony to successfully be able to practice that. So again, first of all, he tapes his fingers together so that they're working as a block. He provides external focus to the practice. So Tony is moving his knuckles, his PIPs to touch the bottle. So that's the external focus, is to move those knuckles to the bottle. And now he's also added in some paper there to reduce the friction. So he's done several things in order to make the task achievable for Tony. And so you can see here, he's just giving him some manual guidance to indicate, and then Tony successfully manages to achieve that MCP extension. So he's modified the task in several ways for Tony to be successful. Here we see a stroke survivor with a really significantly weak leg, but they've been set up to practice in their bed. So what has happened is a task has been created that somebody with a very weak leg can have some success at performing. What would need to be very clear to this stroke survivor is the relevance of this exercise to their goals, because their goals are probably standing and walking, but it's probably pretty easy to explain the significance of having strength in your knee extensors to the ability to stand and take your weight and to walk. And so the person pushes down into knee extension. The sphygmometer is sitting underneath their knee. And so when they extend and push down with their foot against the block, which just makes it a little bit easier to get that context of pushing down with your knee extensors, the pressure moves from 40 to 50. So they can see that they're achieving some success even with this very weak leg. Here we see a lady called Ivy, and Ivy's been walking. Well, you probably can't really call it walking, but she's using a forearm support frame. She's got two therapists with her. She's highly anxious. You can imagine somebody who can't stand and support their weight well, and then they're on this wheelie device that's going all over the place. She's got two therapists pushing her forward, and because she's so anxious and probably has some perceptual problems as well. She's really pushing her center of mass back. And Kate Scrivener here says that this practice made her extremely, extremely anxious. But you can see it's also not achieving anything. And it's certainly not going to make Ivy feel that she's doing anything that's successful. She's really just being pushed around by the therapist on this very scary device. So probably really quite an aversive experience, I would imagine, for Ivy. And now you see Ivy practicing standing up with, again, a table in front of her. She can get herself up into standing with almost no help from the therapist. And once she gets up into standing and she takes her center of mass a little bit further forward towards the table, she can almost take her hands off the table and almost stand without holding on. But can you imagine the difference for Ivy in practicing something that must be awful and really quite terrifying for her to practice, to practicing something where she feels safe because the environment has been set up to make her feel safe. And she realizes that she can get herself up into standing and start to stand with almost no assistance and almost start to balance with her hands off. So let's have a look at what it feels like to be practicing when a task is too difficult and it's not achievable. Tamina Levy has done some qualitative work interviewing stroke survivors about their experience of a home exercise program targeting working on their arm, their affected arm. And this is some of the comments from people about exercises that were too hard to do. I'll let you read through that. Yeah, so if it was too hard, I didn't do it. I got frustrated and I just stopped. Why would you persist? It's something that's too hard for you to feel like you can do any adequate practice. It was no good. And the second one. And again, there you can see the stroke survivor talking about how the motivation to practice disappears as their frustration increases. So they've been given things that are too difficult for them to do, and it leads to a disengagement with their practice. Now we're going to listen to Brian Beh talking about what it feels like when it does work and when it is made to be achievable.
You've looked at what happens if the exercise or the repetitions are not successful or are not relevant, and it leads to a disengagement. Well, when the exercise is relevant and the stroke survivor can perform it successfully, and often it leads to further engagement, it leads to an indication that the survivor is progressing down the rehab trail, and that only adds to the motivation and the engagement of the stroke survivor and the clinician, thereby ensuring the future success of the rehab.
Yeah, thank you, Brian. Brian, I might add on another question, because that just made me think about the fact that when you started your rehab, you literally had sort of grade 0 strength in your right leg.
Yes.
So it actually might have been quite hard possibly for people to set up exercises in which you could feel some success. But was that achieved back then, do you think, when your right leg and your right arm were very disabled?
Yeah. That's a very good point. Look, when I started my rehab, I had 0 out of 5 strength on my entire right side. So that included my arm and my leg. Now, when my rehab started, there was considerable difficulty in finding an exercise that would be relevant. For example, I couldn't do any stepping or whatnot, so we had to work at building strength particularly in my right leg. So therefore, a lot of it was strength building on the knee extender device. I couldn't do any stepping, as I've said, because I had 0 strength. So we focused on just building the strength, and it worked. I started to get an improvement, and so therefore there was one particular day, and allow me to become anecdotal, when I was doing an exercise with one of the students who were on placement, and he said after the exercise, let's sit and see how you can go with your big toe. Because prior to that exercise, I couldn't move it, and I didn't even attempt to move it because I thought that there was nothing there. But I found that I could, when I looked at my big toe, I could move it about half an inch on the axis. So therefore, that was an indication to me that the brain was talking to my extremities. So therefore, the kick that it gave me, it was a real tipping point. So it sort of then kept me going.
Yeah, yeah, yeah. And I guess the other thing that must have been important is back when you were doing the exercises that, like you say, you weren't standing and stepping and things that are immediately obvious as to how they're relevant to walking. You were doing a lot more isolated strengthening when your leg was very, very weak. Do you think it was always clear to you how that isolated strengthening was relevant to your bigger goals of standing and walking?
Yeah, it was vividly clear, because one thing I insisted with the clinician, that every exercise we did, they had to tell me what the exercise was, what it comprised of, and how was it going to assist in me achieving my rehab objective. So I was totally cognizant of what it was and what the benefit would be if I kept doing it. And it made me realise that if I was to do it 10 times, it was useless. I had to do it 1,000 times. So that was the other message that I got out of that, was there were some really big numbers involved.
Yeah, 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 yeah. So I guess that's a good message for therapists, in that some stroke survivors might not be asking that question and saying, explain to me and tell me how it's relevant. But the therapist absolutely has to be making sure that they are ensuring that the relevance is very obvious.
And it gets back, Simone, to what you were talking about, was engagement. If there is a sense of engagement or rapport, and that's an emotional linkage between the two, is that not only could the clinician broach the subject of big numbers with the stroke survivor should not be reticent about talking to the clinician about how many repetitions are involved in the overall rehab plan.
Yeah, yeah, yeah. Okay, well, thank you very much, Brian.
Thank you.
The next area that therapists can have a very significant influence over is making people aware of their capabilities. And here, I think we can create clear evidence of people's capacity to practice and their capacity to produce an output. So we'll have a look at some examples of that, and the fact that their practice means that they change. So how do we make that very, very obvious to people? And can see this is obviously an absolutely key feature of changing people's self-efficacy, and their self-efficacy is critical to their engagement to practice. Why would you practice if you feel that you cannot do it and cannot achieve anything with it? People need to be made aware of their capacity to practice and to change and to produce an output, even if they've got very, very weak muscles. So here you can see a man with very weak plantar flexors that is pushing into some scales. And if you have a look at the scales, you can see he increases only by a few kilograms. But for him, and you can see when he switches on his plantar flexors, he gets barely any movement of his leg because his plantar flexors are so weak, but he does change the output on the scales. So that can show him that he does have the capacity to produce an output. Here you see somebody practicing shoulder protraction. And what's been set up here, which is very clever, is an exaggeration of the amount of movement. So when you think about protraction, it's only a few centimeters really. And so that cylindrical device with a straw attached means it really exaggerates the amount of movement that's being produced. So it really highlights the output that's being produced. And here again, we have the lady, the stroke survivor, with a very weak leg, and now she's pushing down onto scales. And when she pushes down, the weight changes from 5 kilograms to 9 kilograms. So it's really, again, showing her that she can produce an output with that very weak leg. Here we have a practice sheet, which is recording how much practice somebody's doing and also their change. And I think if we can have systems in place where we count and record the repetitions of practice that people are doing, that is an extremely strong evidence for them of their capacity to practice. So here this person has done 136 repetitions, and a lot of people might think that they can't achieve that sort of number of repetitions. But if they're all being counted and recorded, then you really have clear evidence that they do have a capacity to do many repetitions of practice. And also what's being recorded is what you might call knowledge of results feedback. So they're an outcome that is changing, and here what it is, it's the number of reps that are being achieved within a certain time frame. And as they practice and improve, that number of reps is increasing over time. So clear evidence of their capacity to practice and their capacity to change. And here's an example from Concentric Rehab of John's walking practice. And so it's the time taken to walk a set distance. So you can see the time taken is decreasing as his performance changes. So again, clear evidence of the fact that he's changing as he practices. And here this lady, here's her goals, and here's her achievements, that she's been able to walk 5 meters, then with less assistance over time, and being able to stand better over time. And that's all recorded to show her really clear evidence of her capacity to change. Here we have a man doing some therapy.
All right, your tongue went up. It was good. La. Well done. Mo. Where were your lips? Together. La.
And you can see with this man, he's actually evaluating his own performance. So he's being prompted to decide whether it's a good or a bad repetition, but also to identify what are the critical features that make it a good or a bad repetition. So that, you can imagine, is really going to build his awareness of his capacity to change the sounds that he's making, and to even to be able to evaluate them himself as well, according to his, and think about how successful he's being. And the recording sheet here is such that that an alpha is a successful production of the sound and a beta is an unsuccessful production of the sound. But you can see here that then you could make some knowledge of results feedback. So this many successful repetitions out of this many attempts, and that could give this man some clear evidence of his change from session to session and from week to week with his practice. Here we have an example of celebrating somebody's capacity to practice and change. And so this was something that we put out on social media. I was doing some tele-rehab with Belgium Benny, a stroke survivor who lives in the UK. And so we've got his numbers of reps. So he's doing large numbers of reps each day, the improvement in the exercises that he's doing, and what that means across his walking speed. So really clear evidence of his capacity to practice and to change. And Brian, who spoke to us earlier, again, you can see very large numbers of reps across this 2-week block. Big changes in the specific exercises he's doing, and big changes in his walking speed. So very clear evidence of his practice and his change. So last year, with some honours students, I did a randomised clinical trial looking at the effect of counting and recording reps and giving people target numbers. And we've talked about this in the context of showing people that they can do large numbers, but what it also really resulted in is a very, very significant change in the people's increase in the amount of practice that they do. And I think that probably really speaks something to the fact that they're getting clear evidence each session that they can do this and that they can build on what they are doing. So after 5 sessions, the experimental group across these 5 sessions had all repetitions for the exercise that they were doing counted and recorded, and then they were given a target number, which was a 25% increase from their previous. And at the end of 5 sessions, the experimental group, the increase in their intensity of practice as reps per minute was 120% greater than that in the control group. And you can see even the lower end of the 95% confidence interval indicates a difference of 40% greater increase in intensity of practice for that very small intervention of counting and recording repetitions and using a target number. What you see here is the change session by session. So you can see they were asked to see if they could increase by 25%. So originally in the experimental group, they were beating that 25%, and then it starts to drop off, but they still are continuing to increase their intensity of practice. And in the control group, who have none of the counting and recording of practice or the target numbers, you can see that sometimes they do increase, sometimes they go backwards, but it meant that across the 5 sessions, the consistent increase in intensity of practice in the experimental group led to a much greater intensity of practice. So that counting and recording of repetitions, the use of target numbers, really reinforces for people the fact that they can do a lot of practice and that they can increase their numbers and their repetitions of practice. And I would imagine probably does actually really help to engage them in their therapy, because they really know what they're doing and know that they're changing their numbers. What about perceived treatment demands? Remember, that was another one of the big features leading into that willingness to practice and engage with practice. I think this needs a very clear discussion with the therapist and the person that's doing the rehab about the fact that really change doesn't happen without very large numbers of repetitions. That neuroplasticity is dependent on doing hundreds and hundreds of repetitions of practice. And that there might be some quite reasonable sort of timeframes needed to see change, and that will depend a little bit as to how long after a stroke somebody is, but certainly that change can always be achieved after stroke, many, many years after stroke, if sufficient repetitions to achieve neuroplasticity are done. And so that discussion leads into really what works for people and their lives at the time. Do they really want to keep slogging away doing fairly low numbers? Or is there a number that they need to do really just to maintain current levels of function? And then do they want to come in and do an intensive burst towards a specific goal? What works for people in their lives, considering that achieving neuroplasticity and changing outcomes does take some reasonable amounts of work. So that's the perceived treatment demands leading again into perceived self-efficacy. But you can't really have that conversation without really starting to provide evidence to people that they can do large numbers of practice, that they can increase the amounts of practice that they're doing. And that's absolutely dependent on having those systems of counting and recording in place. Okay, so we paused when we did the live presentation of this. We paused here for questions or comments, and I left this slide in because I thought it might be worthwhile speaking about what some of them were. So we had a question about the clinical trial that I was telling you about. What are the sort of things that people were practicing when we were looking at that effective counting and recording of repetitions of practice? So those sessions, some of them were done with a physio, some with an occupational therapist, some with an exercise physiologist. So it was actually a great variety of things people were practicing. Some people were doing lower limb practice, some people were doing upper limb practice, and some people were doing isolated strengthening, some people were doing practice of a whole task. So it went across all tasks. I'd like to add into that is the fact that we actually looked at the quality of movement in that clinical trial as well too, with a visual analog scale of people's quality of movement, and just to tell you that that the experimental group, even with a much, much greater increase in their intensity of practice, did not deteriorate their quality of movement. So obviously had room to work a lot harder than they were without it leading to a deterioration in the quality of what they were doing. Obviously, you will get there eventually, but they did have big room for working a lot harder when they were really getting that feedback about what they were doing and what their numbers were. We also got asked about how you apply this to people with significant cognitive and attentional problems. And I guess what I would say to that is that in all those videos that we looked at of stroke survivors working, we are mostly looking at people that are very early after their stroke and still do have really some quite significant cognitive and attentional difficulties. And that this probably applies even more so, I would imagine, if you're trying to engage somebody in their rehab, that you absolutely have to find something that they can do without them being dragged and pulled around by a therapist, but something where they can achieve some success with it, with people feeling that it's their active practice that they are doing. Which leads us into disengagement. So what, in this model that we're looking at, what leads to ongoing engagement or disengagement? So if somebody finds the experience enjoyable or worthwhile, so I don't think practice has to be incredibly enjoyable as long as people understand that it's worthwhile and relevant to their goals, then you get maintenance of engagement. Conversely, if people feel that the experience is pointless or aversive, well, goal was achieved, that's great. And so you don't need to do more. But if people still haven't achieved their goals, but their practice is pointless or aversive, if we could think about Ivy walking on that forearm support frame and how terrifying it probably was for her to be wheeling all over the place and being pushed around by these therapists, that would be a very aversive experience. And you can imagine Ivy just saying, just leave me alone. I don't want to do that anymore. Why would she want to do that anymore? It would seem pointless to her and it would be aversive. So you could really expect some disengagement there. So we need to really think very, very carefully about how we make sure that people's practice is not pointless, that it is relevant to their goals and it's not aversive because they are achieving some success with it. So if we set people up to practice things that are really meaningless or irrelevant to them, and you often hear stroke survivors talking about sitting there having to stack cones or move beams from one container to another. So we need to find things that are goal directed. What are their goals for their upper limb activities? What are the things that are meaningful to them that they want to practice, rather than things that could be perceived as being meaningless or irrelevant, because maybe they are completely meaningless and irrelevant to their lives. If people are practicing but are not getting any change with their practice, then that, you can imagine, is going to make people feel that their practice is pointless. So we need to ensure that people are doing sufficient dosages of practice, that we've done some reasonable analysis of what their problems are to set up appropriate practice, and that they are changing. And we should expect to see change with practice. If people are not changing, they're not practicing the right thing, or they're just not practicing enough, which I think is a very common problem. And if it's aversive, if it's too hard for people to experience success, if it makes them feel very anxious and fearful, so things that challenge people's balance, people need to be really surrounded in order to feel safe. So maybe a wall on one side of them, therapist on the other side, big table in front, whatever it takes to make people feel not anxious, but for it to be effective at the same time. So not holding on if they're really trying to improve their balance, for example. This speaks something to the need for people's rehab and their practice to be them actively practicing, not being facilitated by a therapist. So in this randomized controlled trial, the researchers were interested in apathy. And apathy, they've defined, as you can see here, less goal-directed behavior, demotivated, so disengaged, essentially, from rehab. What they were comparing was a motor relearning program with Beh therapy. And so what we have is a motor relearning program, which is about active participation, because it uses motor relearning theory, in which we know that people need to actively practice the things that they are trying to get better at doing. And compared that with Beh therapy, which is dependent on the therapist with their hands on facilitating movement. So very, very different types of therapy. And they measured change in apathy across 12 months using an apathy evaluation scale. And what you see here, so this is at the beginning of the trial, the proportion of people without apathy. So the blocked in line is the people that are doing the motor learning program. And you can see at the end of the 12 months, there's a much higher proportion here that do not have apathy than in the people that receive the Beh therapy, who have a higher proportion of people with apathy. And they estimated that if the people that had the Beh therapy are actually 1.6 times more likely to develop apathy. So it's very, very important for people to be actively practicing and not being moved around and facilitated by a therapist, because that will also result in disengagement. And fatigue. Fatigue is obviously not going to be helpful for people to be engaged in their practice and in their rehab. What I'm highlighting here is some variables that a therapist can change that have an impact on fatigue. One is cognitive overload. So if we set up practice that's too difficult and too demanding of people's attentional capacity, and that's very easy to do, because when people are trying to learn a motor skill that they're not good at doing, their attentional capacity is very, very taken up just with doing the practice. So we need to make sure that we don't overload people's cognitive capacity. People feeling unsafe will do that straight away. If people don't feel safe, if they feel fearful of what's going on, then that will really interrupt their attentional capacity and overload them cognitively. If we use instructions that have an internal focus, that also leads to cognitive overload and is not effective for people's motor learning. And so as an example, if we think about somebody who's standing in some hip flexion, and quite a common instruction a physio might say to that person is, squeeze your bottom muscles as hard as you can. That's an internal focus instruction, because it's talking to the person about their muscles without any reference to the outcome of the movement. If we wanted to give that an external focus, we would put something in front of them and say, take your tummy to touch the table. Okay, so it's about the outcome of the movement. Them moving into more hip extension takes their tummy to the table. And so that is used as the instruction. So that has an external focus. If you think about the man that Carl had set up to practice when Tony was practicing, Carl had set him up with, he was practicing MCP extension. He'd put a bottle here. And so the instruction was take your knuckles to the bottle. So it's given that movement that has an external focus. Is about the outcome is to get your knuckles from here to here. And that is much, much easier on people's information processing. So it really decreases cognitive overload, whereas using internal focus instructions leads to cognitive overload and is not effective for motor learning. So internal focus alone overloads people's attentional capacity. It actually results in people needing to use more EMG activity and having more co-contraction with their movements. If we yabble at people, give them too much verbal instruction, too much unnecessary instruction, or not instruction, just fluff, then that overloads people's attentional capacity and makes them feel fatigued as well. No, you don't need to read this at all, but this is a 1-minute voice memo. So you imagine the stroke survivor, and actually the stroke survivor, this was a feedback session, and the physio was talking like this, and this is everything that she said in 1 minute. And after literally only about 2 or 3 minutes, the stroke survivor in this session started to say, I'm too tired, I cannot do any more today. Please take me back to my bedroom. I'm too tired, I just have to stop. So she had actually made him feel very, very fatigued because she was going blah, 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 blah. Complete cognitive overload for him, and completely interfering with his ability to practice. And if you look in green now, actually, I really think that if that's what she had said to him, rather than all of that other stuff, he would have stayed there and kept on practicing. He wouldn't have had that cognitive overload and that fatigue. So overload and underload. Underload can result in fatigue. If people are just bored with their practice because it's not really relevant, they don't feel like they're changing, they just need to do something a bit different, then that will also lead to fatigue. Or if their practice feels irrelevant to them, imagine that is going to make them feel disengaged and fatigued. What about therapist engagement? So there's some work that's been done, in particularly some of the qualitative work looking at engagement, that also really speaks to therapist engagement. And it's one of the first things that comes up when you start to talk about engagement and motivation, is that it's very, very dependent on the therapeutic relationship between the person and the therapist. And if the therapist is disengaged, then that means that the person will most likely end up being disengaged as well. And so what was identified in this qualitative study was that the engagement of the clinician was absolutely critical for the engagement of the stroke survivor. Then they explored this a bit more about what sort of things made clinicians feel disengaged, and what the clinicians identified was that if they didn't feel confident about their skills, they felt disengaged. If they didn't feel that they were helping to change people's outcomes, they felt disengaged. Or if there's some kind of emotional response going on between the person, with something to do with the person they were working with, or some other sort of interaction going on at the time, then that could make them feel disengaged. So I think what's really critical here is to think about upskilling people if they don't feel confident in their skills for setting up active, intensive task practice for people's rehab. That maybe they need to do some more professional development, maybe they need more mentoring, but absolutely critical that we engage and mentor, particularly our junior clinicians, so that they build the confidence in their skills and have skills that are really having a positive impact on people's outcomes. And this statement that the therapeutic relationship is absolutely paramount. I've run a few panel discussions with stroke survivors and a TBI survivor and an adult woman with cerebral palsy, discussing the things that impact their motivation to practice in rehab. And the first thing that will always come up will be the therapeutic relationship. They need to have confidence in, and they need to trust the person that they're working with. And for that, the clinician needs to be engaged. And at this point in the live presentation, Clive Kempson, a stroke survivor, made the comment that it is immediately obvious to people whether the clinician is engaged or not. So absolutely critical to be engaged and to be investing into that therapeutic relationship. So the building trust and rapport, of course, motivational interviewing is a very good way of doing that, and we can certainly pick up some of the features of that, which is really about putting the stroke survivor, the person in rehab, at the center of everything and finding what's important to them in their lives, not the therapist up here telling them what is and isn't good and what they should and shouldn't be doing. helping to educate people and empower people. So some take-home messages. Take-home messages is that therapists absolutely need to take responsibility for engaging people in rehab, and we've really had a look at the very critical things that we need to do to help engage people in their rehab. We need to be very critical and evaluate the therapy that we're setting up for people. Is it relevant to their goals? Is it set up so that they can achieve success? Are they getting some really relevant and timely feedback about their change in their performance? And really being absolutely mindful about the impact for stroke survivors and their families about the way we set up practice, and that it engages people, and that we absolutely must be fully engaged in that process. Because if we're not, why would anybody else be engaged? So you absolutely have to be passionate about doing the best job that you can do in setting up people up for success, measuring their change, giving them feedback about their change, to ensure that people are engaged in their rehab. And here's some references for you for some extra reading. And if you haven't read it, it's not listed here, but Gabrielle Wolfe has also written an article. If you search up the optimal motor theory, it's about a theory about motor learning, but again speaks to a lot of these features about people having to have some empowerment and having to experience success for motor learning. Thank you very much.